It's an honor for me to invite Maninder sir for taking this case-based learning discussion for all of us on non-invasive ventilation and HFNC. Specifically, we are going to talk about respiratory syncytial virus, bronchiolitis, asthma, and troubleshooting is the most important aspect which every clinician should know. And none other than Maninder sir can do justice to this topic. Without wasting much time, sir, let's start.
Hi everyone. So before we begin, let me show you today's case. So if you can see this is a CT scan. So this is you can see one trachea coming from top, and then it divides over here, and then there's obstruction here, and then it divides over here. So this is actually the left bronchus, and this is the right bronchus, and over here the compression on the bronchus is by the subclavian anomalous pulmonary arteries that have come. It's a pulmonary sling. And over here, one more bronchus that you can see. So this is the right main stem, this is the left main stem, and one bronchus going from top. This is called as a pig bronchus. This is the anomalous origin of bronchus. Now, if we follow this video, if we go from top, this is a trachea. We are going down, we are going down, we're going down, and we can see the bifurcation over here. Now we assume that this is the right anomalous bronchus, whereas this is a trachea which is continuing down, and this is going into this is a trachea, and this trachea is now engulfed by the anomalous origin of the pulmonary branch from the pulmonary artery. And then almost a trachea is hidden over here, and we still go distally, then we can see actually the two bifurcation, the right and the left happening. This just to show you how much advanced and complicated the disease have become, and we need to be updated with what is latest. So let us start with RSV, because this is everybody should know about RSV, though we tend not to follow what is given in guidelines, and I'll make it very clear why we should follow the guidelines. So let us start with the case. I'm not going to bore you with the pathophysiology. So this is an 11-month-old baby, has fever for 2 days, has cough for 2 days, has minimal chest cold and drawing for 12 hours. It's a preterm, so you know it's a risk factor. The child is not feeding well for the past few hours. The respiratory rate is quite high for that particular age. Heart rate is okay. Saturation is also okay in room air, active. And there's minimal subcostal indrawing, but air entry is good. And there are some rhonchi, and temperature is 100. So my question would be, what is the most likely diagnosis in an 11-month-old child? First episode which has happened, and definitely kid has a risk factor preterm. So we all know that it looks like a bronchiolitis. Let us not go into the nitty-gritty of it. And will you admit this child? The saturation looks good. There is only mild subcostal indrawing, and the history is only for 2 days. And indrawing is there for the past 12 hours. Or would you send the child home on some therapy? Like a paracetamol, you will give some nebulization, I'm sure. So whatever you do, let us see what exactly which should be done. So this is bronchiolitis. So if you see, this is a normal bronchiole. So bronchiolitis is a disease of the terminal bronchioles. It's not a disease of the main bronchus or the bronchioles. It's a disease of the terminal bronchioles. And you can see the patency which is there is good over here. And over here, what happens, this RSV virus, it actually goes and eats away the epithelium which is there in the airway and produces a huge neutrophilic response. It is not an eosinophilic response, it's a neutrophilic response. And because of which because the tubules, the terminal bronchioles are there, which are very narrow. So the debris are produced over there. The mucosal pump doesn't work, the ciliary pump doesn't work. So there's a lot of clogging of the terminal bronchioles or the respiratory bronchioles by the neutrophilic substances which are there in the airway. So if it is a neutrophilic response, the steroids won't work. and as such, it is in one of the terminal bronchioles. So smooth muscle is not there and the beta receptors are not there. So we don't expect the bronchodilators to work even. So there's no point of bombarding the child who is mild to moderate bronchiolitis with steroids and bronchodilator just because the child has a rhonchi. The rhonchi over here is not due to bronchospasm. It is due to the clogging of the smaller airways which are there, not due to a hyperreactivity, not due to a eosinophilic response. So this is broadly what I'm trying to say. In a bronchiolitis, in a small child which is less than 2 years of age, this viral infection eats away the epithelia which is there in the airway. And there's lots and amount of debris which is happening with minimal smooth muscle involvement. Whereas in asthma, it's an airway inflammation with hyperreactivity, eosinophilic response, and a spasm which is happening. So over here, the steroids and bronchodilators will definitely work. But over here, to give steroids and bronchodilators, as far as pathophysiology is concerned, it doesn't make sense. But you are giving it just for your sake that I have to do something, then that cannot be, that is not logical. So over here, we expect this bronchodilator response to be poor. Steroid response will not be seen. Over here, mostly hyperinflation will be there because once you take an inspiration, the airways open up and during expiration, they close down. And it's usually a 1 or 2 episodes in one lifetime, this bronchiolitis. It doesn't happen every 3 or 4 months. If it's happening every 3 or 4 months, it's not bronchiolitis. It is something else. And it's most likely caused by the viruses, starting with RSV. And there can be now number of viruses which can cause this, from your rhinovirus, adenovirus. All this can cause bronchiolitis. Now, this is what I want to show you basically, that asthma acts at this level, bronchioles level, whereas bronchiolitis acts at the level of terminal or respiratory bronchioles. They are very different. Over here, the mechanism is much different. It's a spasm which has happened here. Over here, it's the clogging of the airways that has happened. And clogging cannot be broken down by your steroids or by your bronchodilators. So let us come back to the risk factors. As we already know, the risk factors are a child who is less than 3 months of age, child who's premature, they have a hemodynamically congenital heart disease. Now imagine there is a not a hello.
हाँ सर.
Okay, because just the light went out, so I thought internet got disconnected. Okay. So it's not a normal ASD, VSD, but a heart disease in which the patient is literally unstable. Those patients, if they get RSV, it becomes a problem. So you should know if a child has some atopic predisposition, that means if the family has a history of urticaria, has a history of asthma, has a history of some skin disorder, then that child definitely is a risk factor. And never forget this parental smoking. It does not mean a direct smoking, but if the one of the parents is smoking outside and comes back, he still carries the nicotine with him. So then comes the definition. How do we define RSV? Because some guidelines says less than 2 years and some guidelines say less than 1 year. So let us be very clear. Some of the European people have been categorical about it, that bronchiolitis will happen in children less than 1 year of age. Whereas the rest of the world accepts it that the children less than 2 years of age are predisposed to have bronchiolitis. Now, this age is very important because after 2 years, if a child has RSV, then it will be RSV pneumonia. It will no longer be RSV bronchiolitis. And Nitin, you are audible. Nitin? Okay. So, what I was trying to say is, European people say it is less than 1 year of age, and they say only the first episode. The second episode is not bronchiolitis. Whereas the AAP and the rest of the world says any viral URTI can cause bronchiolitis and can be recurrent also. But what do we label a RSV infection which happens after 2 years of age? We don't call it RSV bronchiolitis, we call it RSV pneumonia or adenovirus pneumonia. We don't call it bronchiolitis because the whole pathophysiology changes. Now RSV, because the kids' airways have become bigger, it is not the smaller airways which are creating a problem. So physiology changes, more pneumonia when the child's age become greater, and the treatment might change after 2 years. So our treatment for bronchiolitis is specific for children less than 2 years when the terminal bronchioles or respiratory bronchioles are actually very small in that age group. So let us see what the various countries have told you the age limit. So age limit, most of the countries say less than 2 years, whereas few countries say it is less than 1 year. So then first episode is only for Italy and Finland. Rest of the people might say it's not a must. It can be recurrent also. And the findings, again, people have been very categorical about that you should have a crackle. Crackles are must to diagnose a bronchiolitis. These might not be a part of bronchiolitis. So we should understand that how the various countries are coming down to these guidelines because they don't want people over treating these diseases by the medications which actually do not work. So viral testing, that who should we do RSV? So if there's an epidemic of RSV, the government in other countries actually do regular screening and they'll tell you that a RSV epidemic has happened. And then you should know that, okay, now this is RSV season. I don't need to test it because I know by clinical suspicion that it is RSV. But in those places where the government is not doing this recommended testing or not telling the people, then in that particular locality, you can do testing for 3 or 4 patients and you know RSV has come positive, and then you can label all others can be RSV too. So WBC and lab work is not recommended by many of the guidelines, but we have a tendency to send the CBC and fall for the high leukocytosis and also for leukopenia. It can happen both, but it will not change the management. High WBC does not mean bacterial infection and low WBC does not mean that there is severe bone marrow suppression. It does not mean you don't need to give antibiotics just because it has happened. Then blood gas, it is only done when the patient is in ICU, not anywhere else. You don't need to do a blood gas. So if the patient is in ward or if the patient is in your OPD is not needed, but only if the patient is in ICU and you think that the patient might go for a ventilation, not even for HFNC. But if you think my patient might go for a ventilation, you'll do a blood gas. Chest X-ray is actually discouraged by many people because once you see a chest X-ray and you might see a collapse which is there and you label it as consolidation and you will give antibiotics because you have to understand the pathophysiology. The airways get clogged, and because of that clogging, sometimes the lung may get distal to it may get collapsed, and then there'll be a bombardment of antibiotics that will happen, though it's a mechanical collapse, not a consolidation. So treating hilar infiltrates, treating bronchovascular markings will lead to overuse of antibiotics. Therefore, chest X-ray is not recommended. But if you want to do a chest X-ray, then you might consider it for those patients who are in ICU, not for ward, definitely not for your OPD. Now comes the guidelines, whether you should do pulse oximetry. Now, all guidelines says if you're sitting in OPD, you should have a pulse oximeter and check for pulse oximeter in these patients. If the reading is falling below 92, then you have to definitely consider admission. Below 90, Definite. Below 92, consider admission. So why this is important? Because some people do not monitor pulse oximeter and the signs can be really subtle sometimes and missed. Therefore, monitor intermittent pulse oximeter in these patients. Also, if you admit these patients and child is looking okay and in the ward, no need to do a continuous pulse oximetry because usually during sleeping time, the saturation will fall below 90. And at that time, there'll be an escalation of treatment which will happen. But if the child is feeding well and the saturation is between 90 and 92, it's okay to monitor them in the ward. But anything below 92, definitely consider admission. Anything below 90, admit. Then comes the treatment. Now, I know many people, many textbooks, everybody has told you, you have to do only these particular 3 things and nothing else is required. I tried to explain you in the beginning why it doesn't work, but I'll re-emphasize it that the only thing in bronchiolitis that works is basically hydration. Hydration can be in the form of IV fluid, or if the patient is taking orally, very well and good, or put a nasogastric tube. Now, I understand that the child would be tachypnic and there would be some amount of hesitancy to start a nasogastric feeding in a tachypnic child. You might feel he might regurgitate and aspirate. Believe me, if you do not give nasogastric feeds, these child will become cranky. And then it will be very tough to understand if the child is worsening because of hypoxemia or if the child is worsening because of hunger. So it's always better to put some nasogastric tube and give some feeding so as to satisfy the hunger cry which is there in the patient. IV fluids definitely is easier to do, but NG tube would be more sensible if you can do it. Supplemental oxygen, when the saturation goes below 90, you have to start oxygen by either nasal prong or go for HFNC. No need to go beyond this because many of the times these patients will respond with this simple treatment of nasal prong or HFNC. Then because these are small children, then we should definitely do nasal suctioning because they're mostly nasal breathers. So gentle nasal suctioning is recommended. The deep suctioning that we try to do might cause a spasm, laryngospasm, or even a bronchospasm. You don't want that to happen. So a gentle nasal suction, keep the child in mother's arm, give oxygen by nasal prongs or by HFNC, and start enteral feeds better. If not, if you are very scared that the child might aspirate, consider IV fluids. Now comes beta agonist, nebulization of epinephrine, and corticosteroids. There is no recommendation of corticosteroids, be it in ER, be it in ward, be it in ICU. No recommendation. It doesn't work. It doesn't work. It doesn't work. But still, if you want to give because you are pushed against a corner, then only those patients who are in ICU, you might consider giving a corticosteroid. And if there is a family history of asthma, or do you think it's a second episode of bronchiolitis and the child has eczema, you might consider giving corticosteroids. But otherwise, there is no role of giving corticosteroids. Then comes beta agonist. Again, no role in ER, no role in ward. But if you're pushed against a wall in ICU, you might consider a trial of beta agonist, indication being the same, family history of asthma, allergy, atopy. And if you think it's a recurrent episode which is happening, then you might consider giving it, but not definitely for the first episode. Then comes nebulization of epinephrine. It is not a routine, but some emergency departments do give it. And they consider giving it in ICU also. But there is no point that if the patient is a mild and moderate bronchiolitis that needs to be kept in ward, no need to give epinephrine. There's no point. If you think the patient requires ICU, you might give a trial of epinephrine. Then comes the hypertonic saline and antibiotic therapy. Now, again, hypertonic saline is being used and 3% is readily available. You can use it. Recommendation is optional or weak. And I think so everybody in India gives 3% saline because there's no other evidence of any other medication working. Then comes antibiotic therapy. Now let's be very categorical about it. What do you mean the signs of bacterial infection, or what is evident bacterial infection? So if there is a UTI which is confirmed by urinalysis, or if there is a bacterial pneumonia confirmed by your X-ray findings, or there is some organism which is growing, or a blood culture is going something which is not a contaminant, and if there is otitis media confirmed by otoscopy, then you can give an antibiotic therapy. Very rarely these children will have a superadded bacterial infection in ward. That means they are not quite sick. But if they come to ICU and they're deteriorating, at that point of time, you might consider giving an antibiotic, might, not a must. Let's see what are the doses and frequency of epinephrine, salbutamol, and 3% saline. So anything in nebulization should be maximum 4 to 5 ml. So if it is epinephrine, 0.01 ml per kg or 1 in 1000, maximum 0.5 ml. Mixed with saline, total make it 4, or you can make it 5 ml. You give it every 4 hourly, and you can give it maximum 3 trials per day. And if no response has happened on the first day, no need to continue it beyond that. But if it has responded and the child has improved, that you might consider it for 1 more day. No need to give epinephrine for 4 or 5 days, and no need to give it every second hourly, whole night, not needed. Then comes nebulization of salbutamol. So 0.15 mg per kg per dose, maximum of 5 mg, every 4 to 6 hourly, only if there is a family history of wheeze, asthma, or there is eczema in the child, then you will consider giving it. Otherwise, this is not to be used. Then nebulization 3%, 4 ml of 3% saline. Every 6 to 8 hourly, you can give it for 1 to 3 days, not beyond 3 days. Usually, you have to understand RSV is a self-limiting disease, a disease of 1 week, maximum disease of 2 weeks. So if the patient has come to you on day 3 or day 4, he is to be seen in resolution in next 48 hours to 72 hours. He should be. So no need to continue giving this epinephrine and discharge them on hypotonic saline also. So what are discharge criteria? So discharge criteria is clinically stable, no signs of respiratory distress, respiratory rate is appropriate, and there is no apnea if the child is less than 2 months of age. If the child is feeding adequately for the past 12 hours and there is no need for IV fluid or NG feeds, you can discharge. Has maintained a saturation of 90% for at least 4 hours, including sleep, then it is fit for discharge. And you tell the parent. So the discharge criteria is the rate which has settled, the feeding which has improved, and the saturation which is more than 90% during sleep are the discharge criteria. So all three. Now, in this patient, bronchiolitis was mild. I definitely sent the patient back, giving on paracetamol, reassured the mother, and explained to her the danger findings of fast breathing and not feeding. And we sent the patient home. Next day, mother brings the patient back with irritability, not feeding. The saturation is 90%. There are intercostal retractions, and you can see crepitations happening. So now over here, I know the saturation has gone below 92. I know over here the child is not feeding. So these are two big markers for me for definite admission. So how do I classify the severity of bronchiolitis? Earlier, it was just saturation. Now, if the feeding is less than 50% of normal, or the saturation is below 92%, I will definitely admit in the ward for a short stay. See, rest of the thing, increase in respiratory rate, moderate retractions are very subjective. But what is very objective is a saturation criteria going below 92 and the feeding, which is less than 50% of normal. That is affected, you will definitely admit the patient. And if the patient is not taking anything and the saturation is still falling, you will definitely consider ICU admission. And the red flags is the child is lethargic, then definitely you will immediately shift to ICU. So in this patient, we did the X-ray. despite my teaching, the residents will definitely go for an X-ray and they will do it, though nothing is visualized over here. If you tell me, then I'll forcefully say, yes, I can see some infiltrates here, but that does not contribute to any management. And this throat panel, we call it, now this throat panel can be done for only 4 or 5 viruses like influenza A, B, H1N1, and RSV and COVID. So it's not an expensive test as far as India is concerned. So you can do these throat panels because these are seasonal and you should know if they are there, then the treatment would be given appropriately. Now comes, it's a clinical diagnosis. You don't need an X-ray, but still people do it. Despite my lecture, many would do it. It's okay. It will just show you some amount of atelectasis, some hyperinflation, and some bronchovascular markings. But you should know the diagnostic dilemmas that can happen over here and differential diagnosis. So pneumonia can be a part because as per the guidelines, the Indian guidelines, any respiratory rate which is high is a pneumonia. Then congenital heart disease can mimic bronchiolitis, and very important, viral myocarditis. So if you're suspecting a tachycardia which is happening very high and not related to fever, then you should definitely think of viral myocarditis. Liver palpable crepitations can both be there in bronchiolitis. But tachycardia, which is not explained by the level of respiratory distress or by fever, is most likely viral myocarditis. And chest X-ray, you might see a big heart, then it will definitely point towards viral myocarditis. So how do we manage now this patient? We give a heated, humidified oxygen. So the oxygen that comes through the normal pipelines that is given through nasal prong are not heated oxygen, and the humidification in that is very minimal. Even if it passes through the water bubble trap, which is there in the humidifiers, because the water is not heated, if you increase the flow, the bubbles and the air which is passing through it will not get humidified. It is just like giving yourself a false satisfaction. I have applied a bubble container in the humidifier and I'm passing it through for the nasal prong. So why do we need this heated and humidified air? Is because those small bronchioles are clogged. Now over here, to declog it, I need to send the humidity down, and humidity will only go if the air is warm. If the air is not warm, if it is cold, the cold oxygen will not clear it. So it's better if we start using HFNC for patients who are worsening despite nasal prongs, or the patient who are shifted to ICU. The HFNC can even be started in your wards. It's not like HFNC has to be started in ICU. Continue your enteral feeds over here. Trial of adrenaline and hypertonic saline will be considered, and observe the child for deterioration. So this is what we have highlighted, that the mainstay would be oxygen, the heated humidified one, clear nasal passages, IV fluids, and fever management. Questionable role is of hypertonic saline and adrenaline nebulization, whereas no role whatsoever of steroids, antibiotics, sedatives might be in the later part, and bronchodilators. So now comes in HDU. Would you prefer to give a HFNC or would you give a CPAP? That's a major question which many of the people ask. Now the patient is shifted to ICU in a high dependency unit. So what would you like to give? So remember, HFNC is preferred over CPAP in cases of bronchiolitis. The major reason is that it is well tolerated. It is well tolerated by the child. It is well tolerated by the mother. It is loved by the nurses, and the doctors have no issue at all with HFNC. So the major reason is HFNC is easily accepted by all the caregivers which are there, including the child. The mechanism is very simple in HFNC. It's a heated humidified oxygen that we need to give, and the oxygen amount can be regulated by these machines. You need to give 100% oxygen. That happens through a nasal prong. So you don't need to give that, the high amount of oxygen. You might give oxygen which is FiO2. You can calibrate the oxygen because of the blenders. So reduces dead space, which is there in the airway, and a very variable minimal PEEP. PEEP is not there in HFNC. So let's not call it a PEEP delivery device. Whereas CPAP is actually needed if the patient is collapsing, but maintaining the airway. You think the patient is having retraction, becoming blue, but maintaining airway, consciousness is preserved. You can give a trial of CPAP. But the HFNC cannulas cannot be used for giving CPAP because the HFNC cannulas, nasal cannulas, have a big leak in them. And CPAP by mechanism should not have a leak. If there is a leak in CPAP, CPAP is not CPAP. So there are separate cannulas for CPAP that are RAMPS cannula. And for HFNC, we have separate cannulas where leak is very important. And the studies have also showed that HFNC is better and even nasal prongs would do the job. Then comes weaning from HFNC. There are certain criteria you should be aware of, like ROC index, which is there in case of pediatrics, where the respiratory rate into heart rate divided by saturation. If it is more than 6, that means the patient is not ready to wean. And if it is less than 4, may indicate readiness to wean. This is still under validation, not yet the standard of care. This is just I'm telling you that you can do this. If there's a high respiratory rate, if there's a high heart rate, if these two are high, that means the ROC is more. If respiratory rate and heart rate are less, then the ROC would be less. This is just to tell you the logic behind this index. There's one more which is very comfortably used in adults, which is SpO2 divided by FiO2 divided by respiratory rate. So because the saturation is top over here, so the ROCs more than 5 is considered a good weaning criteria. If it is more than 10, it is considered a very good weaning criteria. That means it's a good saturation with a lesser FiO2 and respiratory rate is less. So that would be good. So ROCs for adult, ROC for index is different. So where to use HFNC? We have already told HFNC has to be used in the case of ER or ward. You can even used in PICU and stable them. And wean then is also important. But CPAP is only to be used if you are sitting bedside, because these are the patients where HFNC has failed, and these are the patients which are turning blue. Over here, if you put CPAP and you go outside, this patient might actually die. So you have to understand, when you're applying an NIV, you have to sit there, monitor the patient, and if required, early intubation is the answer. So this is just a brief guideline that when the patient is in ward, you can consider nutrition, you can consider supine positioning. This is actually the ICU. If the patient is in ICU, initially you do hydration, supine positioning. And over here now, because in ICU is there and the patient is fighting, you might consider a sedation which is given in the RT tube like pedicloral. Whereas if the patient is worsening and you need to give some amount of sedation in the critical part, you might consider dexmedetomidine, because a patient might not require intubation and patient's sensorium will not be affected and heart rate will be controlled. Be very careful when you're using dexmedetomidine, because the BP might fall because of the decrease in the heart rate. So this is what this guideline is trying to say you, that try to maintain hydration as far as possible by either enteral or IV route. Consider sedation in ICU, but not in wards where they might go unmonitored. Consider nebulization 3% saline, and only in very sick patients, you might consider your salbutamol also. If intubated, these patients, you must understand this RSV is basically spreads by droplets and contact. So it's very important that you follow cohorting of these patients inside your wards or ICU. Otherwise, the children who did not come with RSV will definitely get RSV. So it's very important you cohort these patients. And also, if you see over here, this is the inspiratory tube, and whereas this is the expiratory tube. We put viral filters over here if the patient is intubated. So these filters will actually trap the RSV virus or the COVID virus or whatever virus. It will prevent its spread into the ICU. So remember, start using these expiratory filters on your ventilator. And bacterial infection in these patients, yes. In not in ward patients, not in PICU patients who are in HFNC, but despite HFNC, if they are worsening, then you might consider antibiotic in those who continue to have high-grade fever spike, because they do disrupt the epithelium, they do disrupt the mucociliary clearance, and if there's an endotracheal tube inside, you might consider that this patient is going to have a MDRO or another infection from your ICU. So these patients, you will give antibiotics, that means intubated RSV, and there's a suspicion of a patch or increasing FiO2, then you will consider them. So when to start? Again, this question comes. So you remember that the incidence of bacterial or co-infection is very, very low in mild to moderate, and also very low in non-intubated RSV. So there is no point of adding azithromycin or adding ceftriaxone for these patients, or even augmentin. But intubated RSV who has deteriorated despite your HFNC or CPAP, and because of stay in your ICU, there might be a risk for these patients to get secondary infection. And at that point, you might consider giving antibiotic. Otherwise, there's no point of routinely using antibiotics in RSV. So isolation precautions, we have told clearly that you have to cohort them, limit the visitors, you have to do environmental cleaning, and it should continue for 5 to 7 days. And limit the RSV cross infection, especially in your NICUs and PICUs. So we'll just go with RSV first. I'll go to the second slide about HFNC. So we know what is HFNC. We have seen all this equipments. I think so. If any ICU or ward is there, you should have HFNC. It has almost prevented intubation in bronchiolitis. We have not intubated a bronchiolitis child. So do get this HFNC machine. Any company would do. So the benefit of this, remember the one in the blue is the right thing. It's a warm and humid gas. It gives comfort to the child and help in mucociliary function. Because of the high flow, the trapping of CO2 will not happen. And because the patient is working very hard, you want to give some support. It reduces the work of breathing. And over here, you can control the FiO2. Instead of a nasal prong where you're giving almost, it's no blended FiO2. Over here, you can control the FiO2. What I have told, this P perfect is minimal in HFNC and should not be mentioned at all when you are telling the benefits of HFNC in bronchiolitis. So HFNC is a non-invasive functional respiratory support, but it is not a non-invasive ventilation. So do not call HFNC as a non-invasive ventilation. It doesn't give pressure. It just gives a flow. So it is just a non-invasive functional respiratory support, not a NIV. So you would have seen these springs which are there in the pediatric HFNC cannulas. They're not there in the adult, but in the pediatric HFNC nasal cannulas, these springs are there. What is the advantage of this spring? So the advantage of this spring, which is there in one particular company which makes them, is that it prevents kinking, because these tubes are small and they are very, very soft tubes. So as to preventing kinking of these tubes, this spring was made. And also when the hot air passes through it, some air is trapped, some heat is trapped in these springs. So it prevents condensation. So these are the two important points that you should know why this spring is there in this nasal cannula. It minimizes the condensate and it prevents kinking. Secondly, there are various different companies, various different sizes. You should understand the important over here is that the nose should not be totally occluded. At least 50% should be at least open. So the HFNC works on the principle of leak. There has to be a leak. So it's just about giving a flow to the patient. It's not about giving a pressure. So HFNC cannulas cannot be used to give CPAP to a patient. HFNC cannula can be used only for giving HFNC. And there are particular sizes for it. You can see this red, mostly for preterms, this yellow, mostly for newborns and infants. large, and then XL can go up to toddlers. So you should know why it is important, because within the machine, these cannulas have got a maximum flow rate. So green maximum flow rate is 25. If you apply a yellow cannula and you apply a flow rate of 12, it will not deliver it, because the nasal apertures of those nasal cannula are small, and at 12 it will give turbulence. So we don't want, and will not deliver. So you have to use an appropriate size nasal cannula to deliver the appropriate flow to the patient. And this is there in adult. So adult has a small, medium, and large. And the maximum flow rate in adults would be 60 liters per minute. So if you see, this is a humidifier which is connected to the HFNC machine, and there is a heating wire over here. So heating wire is not within the tube, but it is around the tube.
Sir, screen is not moving, sir.
Screen is not moving. 1 second. Since how much time it's not moving?
From the case 2 slide, it was there, but explanation itself was, yeah. It's now moving. I
Oh,
think we are
I had
good.
to
Good to
close
continue.
and restart. So I'll just tell you briefly that PEEP has no effect. I told about this spring, and then I told you about these sizes. So you should know that what size you have to use, and this is the adult one. And then comes this heating wire. So the heating wire in these HFNC machines are not within the tube. So you can see these two heating elements that you insert into the HFNC machine, and the heating wire is around the tube. It is not within the tube, it is around the tube. Now, why it is around the tube? It's very important, because if it was inside the tube and the flow is given, it would make the flow turbulent, and the patient will not get a laminar flow. So turbulent flow is not tolerated by anybody. So laminar flow is important, and that's why the heating wire over here is outside the tube. Whereas if you see the ventilators, they have heating wire within the tubes, so as to maintain the temperature, so as to prevent condensation. Over here, it's outside the tube. And then you would have seen these type of Rams cannula also. Now these cannulas are different from HFNC cannulas. Over here, if you can see, they're basically, you can measure from the the septal space between the prongs, and also from the diameter of the nasal prongs. Now these Rams cannula should match the diameter, because these are basically for CPAP. These are not for HFNC. They were originally made for giving CPAP to a child. So this RAM cannula is tighter fit. It will create a partial occlusion, which will allow a PEEP effect. It is not to be used for HFNC, but people use it. It's okay. You can put a small cannula, it works for HFNC. The size would be small. Whereas the HFNC nasal cannula is designed for a leak. They don't want excess PEEP to be given. They just want flow, which is heated, humidified, and blended oxygen to reach these bronchiolitis airways. So this is a difference between the RAMs and the HFNC cannulas. You should be aware of it. So applying a RAM cannula to a patient of bronchiolitis, then you have to choose a smaller size. It should not fully occlude the nose. There should be a leak once that RAM cannula is used for HFNC. So let us see this 9-month-old child. Is a case of bronchiolitis. Initial flow settings were 10 liters per minute, FiO2 of 60. The heart rate was 160, respiratory rate 60, and saturation of 98. And this is the X-ray, because I think so nobody goes treating a patient, respiratory patient, without doing an X-ray. But if this is there, now what is important, you should understand this patient is already on HFNC. So before saying what I should do now, you should know what was there before. So this was started 10 minutes back, HFNC. Before starting HFNC, the heart rate was 160. Still it is 160. Respiratory rate was 70. Now it is 60. Saturation was 80 without oxygen, and was 100% on oxygen by hood at 10 liters per minute. And over here, the child was irritable. Now the child has become more anxious but consolable. So if we can see, this was 10 minutes back. After applying HFNC, respiratory rate has gone down, saturation has improved because despite decreasing the FiO2, the saturation has improved and the heart rate remains the same, but the patient is becoming more consolable. Would you like to change anything? So once the saturation is 98, I don't like anything above 94. So our targets of saturation should not be 98. Our targets of saturation should be around 94. Some people might say 95, that is also okay, but not 96 and beyond. So how do you start at HFNC? You start at 1 liter per kg per minute flow. Suppose it's a 10 kg child, you start at 10 liters. And FiO2, they have written as 40. We will start at 60. Nobody starts at a lower FiO2. Everybody starts at a higher FiO2. Maybe if somebody will start at 80 also. Doesn't matter. But if your FiO2 is able to come down within 1 hour to 60, it is good. So you can titrate and play around with flow and FiO2 in the next 1 hour. You can titrate. If your child is not settling every 15 minutes, you can increase the flow from 1 liter per kg per minute to 1.5 liter, then to 2 liter per kg per minute. And the FiO2, you play around between 40 and 60. You start with even 80 and come down to 40 and 60. But the FiO2 should come down below 60. The target saturation over here would be around 94. We don't want a saturation of 98 or 96 also. So this is just a rough formula. If a child is less than 15 kgs of age, the flow would be 2 liter per kg. That means you would give a maximum flow rate of 20. Now, if the child is more than 20 kg of weight, then the flow would be 20 plus 1.5 times the weight in kgs minus 20. That means for every weight which is crossing beyond 20, like if it is 30, then 30 minus 20 would be 10. So 10 into 1.5 would be 15. So 20 plus 15 would be 35. For 30 kg, the maximum flow would be 35. So something like this, a formula, though it is not a standard formula, it is just a temporary formula, but the flow should never cross more than 2 liter per kg per minute. For a child less than 15 kgs and child more than 20 kgs, try to make it 1.5 times. So whenever you apply an HFNC, the heart rate will be the first thing because the child loves the flow, child loves the warmth, child loves the that something is being helped. Then the heart rate will be the first thing to fall. Then a decrease in respiratory rate and rate should also follow. But if the work of breathing is not settling, then you increase the flow and you titrate your FiO2 so as to keep a saturation of 94. Now this patient again coming back to same thing. So what we should do now, we should definitely, because the child's respiratory rate continues to be high, we can increase the flow and decrease the FiO2, target a saturation of around 94, heart rate should fall. So you can increase the flow because the tachycardia has not settled yet. So increase from 10 to 15 to 20, because 10 kg you can go to 20. And FiO2 not required a saturation of 98. So you decrease the FiO2 from 60, 50 and 40. So these are two things only that you can manipulate in your HFNC. So how do you define that the HFNC has failed? Then you definitely need to go for a intubation or your BiPAP or CPAP. It can be clinical deterioration that you can see the child is turning blue or the work of breathing has increased despite your 2 liter per kg per minute, or the FiO2 is not coming below 60 despite your 2 liter per kg per minute. Then you might consider putting the child on CPAP or intubating. So this we have already discussed. So after 6 hours, we know that the present flow setting is 15 liter per minute and the FiO2 is 40. Heart rate is 120, respiratory rate is 45, it is settled, saturation is 9, child is comfortable. Is it necessary to do AVG or VBG in this child who is settled? Should we give nebulization? Should I give steroids, antibiotic, feed, and sedation? Now the child has become comfortable after HFNC, no need to give sedation. If he's comfortable and you feel that a child can take orally, you can feed the child or put an RT feed. Also, this is not a closed system. The CPAP belly will not happen in HFNC. So antibiotics are not needed because the patient has settled on HFNC. Steroids also are not needed because patient has settled. And nebulization, whatever you give, will be more of a moral support, and you can connect the nebulizers within the HFNC. So there are now new nebulizers which can be connected onto the HFNC circuit just after the humidifier. So it will give nebulization to the patient. So you can give your 3% or a epinephrine nebulization and no need to give any other nebulization. And there's no point in a patient who has stabilized to do a venous blood gas just for documentation. It will not change my management. So this is what we have written, that you should follow this clearly, and HFNC will prevent the intubation in these children. Now we follow the present setting is 18 liters per minute, FiO2 was 40, heart rate has settled down to 110. So how do I taper my HFNC? That is a major question. So if the patient is clinically stable, then you should taper it. So let us go down one by one. So over here, at 0 hours, the flow was 10, 15 minutes it become. So after 48 hours, we are stable at 18, FiO2 is 40, heart rate is 110, respiratory rate 45, comfortable, saturation is 91, and all RT feeds. So what do? Because FiO2 has to come all to 40, I decrease the flow from 18 to 15 for a 10 kg child. And I see the heart rate is okay. It has not gone higher by 10%. I see the respiratory rate is okay. Child is comfortable and saturation is maintained. So after 6 hours, again, I maintain the flow, but I decrease the FiO2 35. And I see the patient is still comfortable. Respiratory rate is still within range. Heart rate has not gone beyond a particular more than 10%, and saturation is okay. I again decrease after 6 hours, I decrease the FiO2, and again after 6 hours, I decrease the flow. So when it comes to 1 liter per kg per minute, at that point, I can disconnect my HFNC, or some people take it 0.5 liter per kg per minute. It's up to you. If you want to de-escalate from HFNC faster, you can straight away shift to nasal prongs if needed, or even remove HFNC. And if the saturation at 10 liters and FiO2 30 was 95, on removing HFNC, it will remain around 92, 93. That is comfortable. No need even to give nasal prongs. So this we have discussed the ROX index that was basically used in adults. So if I see a saturation of 96 and a FiO2 of 0.4 and a respiratory rate of 24, then the ROX index over here would be 96 divided by 0.4 divided by 24. So 96 divided by 0.4 would be 240, divided by 24 is the respiratory rate, would be 10. So any ROX score which is more than 6 is good. 10 is very good. You start weaning now. So how do you wean? I've already discussed. Decrease the flow and decrease the FiO2. And if it comes down to 1 liter per kg per minute, you take the patient off HFNC. And usually we do not decrease in night time. We try to decrease everything in day. It's all your institutional protocol. This already also I have discussed the ROC index, which is used in pediatrics. Then comes non-invasive ventilation. Now over here, I would shift to another slide. Show. Okay, 1 second. Okay. So any doubts till now, please write in the chat box. And this is for the non-invasive ventilation. Now, non-invasive ventilation, I'll not try to confuse things. I'll try to make it very simple. So in a conscious patient, you can see the work of breathing is quite high. And this is the amount of effort this child is doing. For this small child, it's like lifting 20 kgs, 30 kgs of weight. It's very, very high. So how do I support this? Somebody helps his breathing. So what can we do? We can either apply a HFNC or a CPAP. But remember, HFNC will give no PEEP. Let's make it very clear. It is not non-invasive ventilation. It's a respiratory support with no PEEP. I don't want to confuse people. Say minimal PEEP, then people will follow that it has some PEEP. Whereas BiPAP is the machine which will definitely give support to the patient in work of breathing. So trial of NIV would be BiPAP or CPAP. This is what we want to highlight. So this NIV can be given at home, or versus there can be your ICU ventilators which can also give NIV, non-invasive ventilation. So over here, if you can see, these have two circuits. There's an inspiratory circuit, then there's a mask, and there's an expiratory circuit. So there's no leak in the system, because this machine should know how much flow and volume I'm giving and how much flow and volume I'm getting back. So this machine will not like a leak and will have a mask which has no holes. Whereas the home ventilator have just one limb which is going over here. There's only one limb. This both it's an inspiratory flow limb. Expiration happens in the mask. So there are holes in the mask, vented mask. So here the expiration happens. And this is just a very simple machine based on turbine. It gives high pressures to the patient, but there is no expiratory limb over here and the mask over here are vented. So this is just the way that a child needs to have his first breath of life, and then if he doesn't have, then there's no life. And the non-invasive ventilation, the advantage is we are removing the endotracheal tube, so there's no WAP. So it's a big advantage. Patient will not bite the tube. Patient will not fight the ventilator. So there's lots of advantages once the endotracheal tube is out. So the types of NIV, the earlier ones were the negative pressure called as an iron lung, which are obsolete. And the newer ones are the ones which, this is like a nasal NIV. It gives a nasal support. So positive pressure ventilation. Or this is the newer types, but we don't use it anymore. We don't have it in India. So what's the difference between CPAP and HFNC? I told you clearly from the beginning, CPAP is a pressure which is delivered continuously through the respiratory cycle. Whereas HFNC is just a flow. HFNC is like once you take your head out of the moving car, you love the flow. A dog also loves it. Everybody loves that flow. But CPAP is a pressure that is being delivered. Nobody likes it. It's more claustrophobic and it has its disadvantages because pressure has to be maintained. Whereas over here, leak can happen. Whenever a leak happens, everybody's happy. So CPAP versus BiPAP. Again, CPAP is a continuous pressure, whereas BiPAP happens during inhalation and exhalation. So over here, the 5 PEEP can be 5 CPAP also. This means the same thing. And the I means whenever a patient takes a breaths, there will be a support which is given to the patient, which is IPAP. So this is just to tell you a baseline PEEP, which is there, is 10 is throughout the inspiration and expiration. Whereas whatever is the IPAP, which is given a support only during inspiration, not during expiration. So just a PEEP of 10 is just CPAP. But once we apply an inspiratory pressure of 10, then the total pressure becomes 25. So that becomes IPAP. Whereas CPAP can be EPAP in a BiPAP machine. Okay, so remember CPAP is a different mode altogether. You should not use the term CPAP when you're using invasive ventilation. When you're using invasive ventilation, the term should be PSV plus PEEP. It is not PSV CPAP. That is a lingo that is being developed. But the correct terminology in an invasive ventilation is a PSV mode, which has a PEEP inside it. We should not call it CPAP pressure support mode. It's a pressure support mode. Patient is spontaneously taking with a baseline PEEP attached to it. Whereas CPAP is a non-invasive ventilation. It is totally different. So this we have already discussed. So clearing the terminologies, CPAP plus pressure support in intubated patient. Over here, PEEP is 5, pressure support is 5. Whereas BiPAP, over here, EPAP is 5, IPAP is 10. So total PIP is 10. So here PS does not include the PEEP. Just to tell you the difference once you're using in an intubated patient and once you are using in a patient who is in NIV. Now this is how a lung looks like. It looks like this in X-ray, but it's not like this. Lung has multiple alveoli, and every alveoli is filled with a different capacity. Some are even not opened, some are maximally opened. And they are very different sized balloons. They're not the same. So, but in X-ray, it looks like one healthy lung. So lung is very heterogeneous. It is not homogeneous. And the purpose of CPAP is to give continuous pressure so as to open the collapsed alveoli. Now remember, when the alveoli is collapsed, it is not taking part in any gas exchange. Gas exchange happens in exhalation also. So if I fill some air in it, however little it might be, as you can see in the video, my balloon that I'm expanding. Now over here, CO2 and O2 will exchange. So you have to remember that CPAP will improve the compliance of the patient, especially in small children or infants who have cartilaginous lungs which collapse. And by giving this CPAP, you will be able to open these alveoli, improve the compliance of the lung. So this is how a lung looks like with no PEEP, and this is how a lung looks like with PEEP. So once you're giving a PEEP, you can see the airways are big and they contribute to air exchange, the alveoli. So there's an IPAP and there's an EPAP. The difference between the IPAP and EPAP is the tidal volume. So difference, the EPAP is the CPAP which is there, which is baseline throughout the ventilation cycle, and EPAP and IPAP is on top what is given during inspiration. So this is what we are telling you. EPAP is throughout, and what is delivered in inspiration is the IPAP. So how do you set this? So there are some respiratory rate also. If the patient is not breathing or has a less, then you can fix the respiratory rate, and you can tell in how much time the TI you can fix. The ramp is how the breath should be given. So if it is a high ramp, then the patient will have lot of anxiety and he will fight the ventilator. Slow ramp, he would like the breath to be given slowly to him. And there's an inspiratory trigger and also an expiratory trigger. And leak should be there, but not higher leak. So this is about the rise time. So if you give a too narrow rise time, there'll be overspike and patient will not like. And too slow means the patient, this is good for when you're in sleep apnea. You want to give, when the patient has not comfortable sleep, he likes breath delivery to be given slowly. So if the patient has sleep apnea, you want slow. If the patient is in ARDS, you need to give breath fast. In asthma, it can be normal, and GBS is again not a lung condition, a neurological condition. And you should have these humidifiers. Now, these humidifiers, if they are not there, you can connect the heat moisture exchangers like this. But if humidifiers are there like this, make sure that the machine remains static on the table. If you tilt the machine, if you tilt this machine, the water will go inside the machine and will destroy the machine. So it's very important in these NIVs with humidifiers that they should be on a firm, stable surface, which should not tilt. And prerequisite of NIV is the patient should be conscious, should be hemodynamically stable, should be able to maintain the airway. You don't want to put in a child who's not able to maintain and will aspirate his secretions. So patient counseling is before very, very important, because once you give a lot of CPAP, patient will not like it. You need to hold the mask, stay with the child for 15 to 20 minutes, hold the mask, stay with the child, counsel him, it's okay, air is coming. And then after 15 minutes, he will like that air. But immediately if you put the CPAP mask and tie the straps, he will fight it out, he will remove it. There are some contraindications you will not use in a patient who has altered consciousness or profound shock, acidemia. If there is a facial trauma or a burn, definitely you cannot apply a mask. So they are, and the child is vomiting excessively or has excessive secretions. So these are the three modes. Spontaneous, when the patient is taking a lot of good breaths, you apply in spontaneous. Timed, if you feel that the breath is not good, is neuromuscularly weak, you can do time, or you can do ST mode, which is like a SIMV mode. So this is what we told you, that this is spontaneous. If you give CPAP alone, the patient will breathe above this PEEP. And if you give BiPAP, it will have both the advantages of PEEP and the inspiratory support also. So the settings would be at a FiO2, always start with a FiO2 of 100%. And in a small child, you will apply an IPAP of 8 and an EPAP of 4. Whereas in a child who's more than 2 years of age, you can start with the IPAP of 10 and EPAP of 5. So you should keep a difference of minimum 4 between the E and IPAP, because this would give some tidal ventilation to the child. Do not keep it same, keep a difference of 4. And if the patient is hypoxemic, then you definitely increase the EPAP, but keep on increasing IPAP also. And if the patient is hypercapnic, then you decrease the EPAP, because you need to give lots amount of tidal volume so that a CO2 washout happens. And once you apply the mask, the machine will tell you if the mask is fitting well or not well. Up to good, leak is okay. Beyond this, 2 stars or 3 stars, every machine has different, leak is not tolerable. Trigger and cycling will adjust as per the disease criteria. We'll take a separate class on that. This is expiratory cycling. And this is the interface. We call it the interface. That this is nasal and oral. So oro-nasal interface. If it is only on the nose, it will be nasal interface. So on the face, it will be a face interface. So there are circuits and there are interfaces, and then there's humidifier. And with this BiPAP, there are head straps so as to stabilize these interfaces. And the circuits can be humidified, or with the HMEF, you can use over here, heat moisture exchanger. So this is what I was telling. If it is basically a home BiPAP machine, then these will be ventilated because this is single limb circuit. The CO2 will come out from here. The expiration will happen through this vent. Whereas if there are no holes in this BiPAP mask, that means it's for a dual limb circuit where the air goes in from here and exhalation happens through one of the circuit only. So you should remember, if you apply this vented mask in a ICU ventilator, it will give a leak alarm. And if you apply this non-vented into a single circuit, that will cause pneumothorax. So it's very important which mask you use for what ventilator and what circuit. So for a vented, you need to have a single limb circuit, making things very clear, because CO2 will exhale from here. If you apply this non-vented mask over here, it will cause pneumothorax because there's no way for the air to escape out. Whereas in a non-vented one, you apply it in a ICU ventilator with dual limb circuit. So one is the inspiratory and one is expiratory. So advantages of nasal mask. Now this is only a nasal mask. So the advantages are many. The patient can actually take the milk. Risk of aspiration can talk also. And disadvantages, when the child opens the mouth, there will be a leak. So there are many different types of nasal masks which can be used. And this is the most common one which is being used, is the oronasal one, where both are being covered, but it has a risk of claustrophobia, aspiration risk, and discomfort. So these are major risk factors. So this is commonly used in our settings, the oronasal ones. And nasal prongs will work only if they're tightly sealed, like Ram's cannula with the sticking on it. Then only it works. Don't put a HFNC nasal cannula and apply to a CPAP machine. That is fooling. You're fooling the physiology. It doesn't work like that. Or you can put the traditional way was cut a ET tube, put it into like a nasopharyngeal air. The size can be from the tip of the tragus, tip of the nose to the tragus, and that is the size you can cut and put, and you can use it. This full face mask, I have not personally used it. And head straps, according to the size, you should be aware of it. Chin straps, again, we don't use it. The complications on mask related are many. Be very careful. This can cause big ulcers over here. Even eyes can get affected. So it's very, very important that you be aware and you give some breaks to these children when you're giving NIV. I think so. I have covered NIV and I have covered HFNC and RSP. Any doubts? Anyone? Open for questioning. I went a little fast, but electricity at my home has gone. So working on the, so anybody can reference for formula for HFNC. The formula that I gave is my own formula, whereas the rock and the rocks are there in the any general. Whereas the formula is my personal. Otherwise, you can see from the net, they tell you have to, after 20 kgs, you have to follow, for 30 kgs, they write 35, for 35 kgs, they write 40. So like that, it's recommended like that. Okay. Ambroxyl nebulization, no role, absolutely no role. Hypertonic saline, yes, you can give. Normal saline nebulization, definitely no role. And oral suction is good, gentle, yes. No need of deep suctions, it will cause more trauma. Respiratory support of choice, definitely it is heated, humidified, high flow nasal cannula. That is HHHFNC. And ipratropium nebulization, it has no role at all, no role of ipratropium. It's not asthma that we are treating. Some doctor give 7%. So 7% nebulization are available in India. See, some doctors give it. I'm not against them. You can use either 3 or 7%. How to give heated humidified oxygen? If you do not have this HFNC machine, then even if you have the MP850 humidifiers or your CPAP machine, the blended, then you can give it. You need a blender. So air and oxygen blender, and it should be heated. So if it passes through, I think so. This Jugaad is well mentioned in literature. Role of antiviral, there is no role of antiviral. Ribavirin should not be used, should not be used. It is not meant for RSV. Only nebulized ribavirin, which is not available in India, has a role in RSV. But oral ribavirin is not to be used. Some people might use it if um, the RSV infection happens in a bone marrow transplant patient. There might be some studies, but ribavirin is off-label and should not be used for RSV infection. Uh, your take on Rams cannula? Yes, Rams cannula can be used for HFNC. Use a smaller size one. Screen not visible. People understand. Okay, sorry. I know why it was not happening. Uh, Okay. Preferred oxygen support in mild and moderate respiratory distress. If the patient is in ward, you can start HFNC, but there's one problem with HFNC, which is now being seen that people start HFNC and then they don't wean. And because they don't wean, the child has an excess length of stay in hospital. So weaning is very important. You might start HFNC in ward, and but weaning, once the child has stabilized, you wean fast. Nowadays, there is overuse and abuse of HFNC also. So be very careful once you're using HFNC. For diagnosis, crepitations is a must in some guidelines. For us, any respiratory infection without high-grade spike in a child less than 2 years of age who is having tachypnea would be a bronchiolitis. Clinical diagnosis is sufficient in a RSV season. I have tried to cover many practical points. How do you start HFNC? 1 liter per kg per minute you start, and FiO2 of 80, and then you titrate it. At the end of 1 hour, you should not cross 2 liter per kg per minute, and FiO2 should not cross more than 60. That is the aim. And if the child is fighting it, then you can sedate the child. You can give a through an RD, you can give pedicloral, or you can give dexmedetomidine also. But it's to be given in those units who have residents and who can monitor the child, because they need to be intubated whenever required. Ribavirin use, it has no role whatsoever. Oral ribavirin I'm talking about. And Fluweed, that Tamiflu only to be used when there is H1N1 infection. Tamiflu will have no effect whatsoever in RSV. So this is some illogical practices that are being used. So if H1N1 is there, you will definitely use Tamiflu or your Fluweed. Oxygen support of choice in neonates. See, I'm not an entomologist, so I will not comment on it. But a child who is more than 1 month of age comes into pediatrics, and HFNC is not bad. CPAP is also good. Depends on the availability and the disease process. If it is a heart disease patient who is in failure, then definitely a nasal CPAP would be preferred because pressure requirement is needed. But if it is a case of bronchiolitis, then HFNC supersedes the CPAP. Compatibility of 3% NEPs you can give. You don't mix it, you give separately. Can we wean faster than every 6? Yeah, you can wean every 4 hours also. The 6 hours is our institutional protocol. You can wean every 4 hours also. While using RAMs and PEDs, we usually give a PIP and PEEP, and your take on it. We usually give a PIP and PEEP more than 20%. You need to keep a difference between the PIP and PEEP. 20% or 2 is sufficient. It's usually 2 or 4 should be kept. You should not match it. 4 should be their minimum. There are too many questions. Which to increase? First floor oxygen and saturation is not increasing. So by default, if the saturation is not increasing, there is an inherent tendency to increase FiO2. So that's okay. If you want to do it, it's okay. But for a longer run, the next thing you would like to increase the flow. So as an emergency or urgency, increasing the FiO2 is not bad. But the flow will be eventually need to be increased so as to decrease the FiO2. Someone told that HFNC use on nasal cannula is same nowadays, decrease day. So what they are saying is the problem with HFNC is being overused and abused, and people put it and they don't take it off for 5 days. So that's why they are shifting to nasal cannulas, because bronchiolitis, believe me, is a self-limiting illness, and if the patient is in ward, doesn't need a HFNC also. So it's not wrong that someone who has told. Which machine for CPAP? I'll not go into the naming of machines. It is not right. I think so. That's the last question. Thank you.
Yet another incredible work